Good morning, and thank you all again so much for being here. I'm Shawn Gremminger, Senior Director for Federal Relations here at Families USA. You remember me from yesterday in the bow tie. First of all, I just want to thank Governor Kitzhaber once again for his beautiful speech. When I approached Governor Kitzhaber, I asked him to provide a sort of moral case for focusing on healthcare value. What I did not ask him to do was bring me to tears before I had to come up on stage. So he and I are going to have to chat about that later. So all of us as consumer advocates hopefully are focused increasingly on the value that we receive, but we can't do this alone. We need allies. And on this stage, we have three of the best allies that we are possibly going to get in this fight. Allies that are adjacent to, but not directly within the consumer healthcare field. I'm going to just very quickly introduce our panel, ask a couple of questions, and then really I want to turn the conversation over to you. As Frederick said at the beginning, on your table there are note cards. If you have any questions or thoughts for us, please raise those note cards in the air. We have runners who are going to come get them, bring them up front, and then we'll use your questions. If you'd like to be identified, just write your name down, and I'm happy to identify you. If not, no problem. You can remain anonymous. So first, on the far end of our panel is Elizabeth Mitchell. She is the president and CEO of the Pacific Business Group on Health. To her right, Rushika Fernandopulle, the co-founder and CEO of Iora Health and also a proud board member of Families USA. And then directly to my left is Randi Weingarten, the president of the American Federation of Teachers. You'll find all of their much more detailed bios on the app that we talked about yesterday. So I'd like to start with Elizabeth, if I can. As you know very well, and maybe our audience does as well, more than half of Americans receive their health care through their employer, and yet costs have actually risen much faster on the private employer side than they have in the Medicare and Medicaid space for a number of reasons. Governor Kitzhaber laid out a beautiful call to action for all of us. How can we really turn that into action? And in particular, what are employers doing to really demand value for their employees?
Thank you, and thank you for having me here. This might be a surprising partnership, but it is really important. I represent about 40 of the largest private companies in the world and public purchasers. And I just want to say for the record, the status quo of the US healthcare system is completely unacceptable. My members spend $100 billion a year on healthcare for over 15 million Americans. And they could not be more frustrated with the value they are receiving for that spend. One of the CEOs of this large company said to their head of purchasing, so for this billion-dollar check I'm writing, am I buying health? And they had to say no. Because at least 30% of that spend goes to waste, administrative waste, price gouging, nothing that we would want to be spending our precious resources on. And that spend is coming out of wages. It is coming out of innovation. It is coming out of job growth. Those are the things that we should be investing in, not a dysfunctional healthcare system. So your question is, so what are we going to do about it? And people ask me all the time, so where are these large employers? They're like mythical creatures, like Bigfoot or the Loch Ness Monster. Why aren't they doing more? We know they're out there. Where are they? I want to say that things have gotten so bad. The good news is they are taking action. And I think that together we can actually make a huge difference. One of the things that we have done over the last 5 years is invested in a Centers of Excellence program. What that means is we identify, using very rigorous quality standards, the best surgeons and specialists in the country, and we support employees to go there. What we have found in that program is over 50% of the recommended surgeries were unnecessary. People were being subject to risky procedures that they did not need. Also, with these top providers, readmissions were cut in half, infections were reduced, aftercare was not necessary because they were getting the right care and it cost less. We were able to prove, this was quantified in the Harvard Business Review, it's not just me, not only were outcomes improved, patient experience was improved, and millions of dollars were saved by getting the right care. So we're trying to innovate and scale innovations like this, and the empire strikes back. The medical industrial complex does not like this at all. So they implement things like gag clauses, where physicians are actually prohibited from telling you the relative cost and quality of a procedure, or all or nothing provisions in their contracts, where you can't select a high quality provider or facility without taking everyone, or anti-tiering, so you can't select a high performing network. They put this into contracts to prohibit large employers from buying the best value on behalf of our employers. But there's really good news. We are starting to see some change. I'm gonna lead with a story you might have heard about yesterday. In 2011, my members took on Sutter Health, which was a hospital system who was implementing all of those anti-competitive practices. And we went to employers and we went to unions and we said, do you know you're spending up to 70% more for this facility because of some of these practices? Over time, we enlisted the AG, and what you may have heard in the last few weeks, we actually won that case. It's the first time, I believe, in US legal history that we have taken on those anti-competitive practices by large health systems and prevailed. There was not only $575 million of damages awarded to the employers and the unions and the employees who had overspent, but there are new rules of the road that prohibit those practices and require transparency, require quality reporting, require accountability. So there is good news. And we need you to partner with us to see this through. We can scale these innovations, we can buy the best quality care, but we can't do it alone. We need your partnership. And that's why I'm so excited to be here and having this conversation. It's exactly what we need to be doing.
Thank you very much, Elizabeth. As you said, folks wouldn't necessarily see that Families USA would be teaming up with big employers, but on this issue, we are 1,000% aligned. We are also very well aligned with the labor movement. So Randy, the American Federation of Teachers represents a large number of teachers and also folks within the medical community. I know that generally unions focus a lot of their effort on negotiating in their contracts good healthcare coverage, but that's increasingly difficult as costs continue to rise. Can you talk about what the impact of high costs are on your members, and particularly what unions are doing to the extent that they can to fight back?
Yes. So let me, just like Elizabeth, I was writing notes and notes and notes of what you were talking about, so we should work together.
Absolutely.
So I come to this as in 4 or 5 different roles. We are now the second largest nurse union. We have physicians, intensivists in our union as well. We are the second largest teachers union. We are the largest higher ed union, which includes thousands of adjuncts who have virtually, like Ryan was saying before on the video, no health care. And as part of, or the former leader of the UFT in New York City, I was also the head of, separate and apart from that, something called the Municipal Labor Committee in New York City, and we were one of the largest purchasers of healthcare, and I spent those basically 10 years being on the union side with the large employer of New York City, that's had over, I don't know, 300,000 lives or 300,000 employees and many, many more lives that we were negotiating for, watching exactly what Elizabeth said, where we should have had huge purchasing power, we should have had huge leverage, and we saw that, and it's only gotten worse over the last 10 years, that this kind of trifecta of health systems that have now become major monopolies, and the insurance companies, and big pharma, actually, and I use the word conspired rhetorically, but essentially had the kind of clout in the market, and that employers and workers had very little clout. Mm-hmm. And it's actually gotten worse and worse. I'll give you one example that just one example, just even in terms of the clout of the market that they have. So one New York City hospital charged an average of $34,310 to treat a complex case of bronchitis and asthma, while another 63 blocks away charged $8,159. One hospital in Virginia charged more than $117,000 for a lower limb replacement, while another charged $25,600 for the same procedure. And there's not the transparency about this. These are things that we've gotten. Why do I say all this? From all of these perspectives, including representing the nurses who are really fighting for higher or lower nurse patient ratios so that they can create a quality of care. Yeah. So as the governor said, it is access, it is quality, it is value, it is cost, and we who are the consumers or even the providers have very little power in any of this. And the incentives are completely misaligned. And in some ways, even when you saw the ACA incentives, because it was a sausage-making bill, one of the most important things that came out of it was not actually the increase in coverage, even though that was vitally important. It was this assurance on pre-existing conditions, because that is something that people see, hear, feel, and understand, that a chronic disease can be a sentence, an indentured servitude sentence of not being able to move employment or anything else. And so the point is, the whole system, the system is completely broken. So from the labor perspective, people know this. Okay, you negotiate health care, that means, and deal with premium costs, that means you're spending less in terms of the negotiation on wages. This is something that is problematic to employers as well as employees. You see this as part of what has happened in some of the strikes in the United States, not just the private sector strikes, but the public sector strikes. In West Virginia, for example, that first strike that happened a couple of years ago, and that is on a statewide basis. The insurance premiums had gone up so much that the West Virginia teachers' wages had effectively decreased to a level of 10 years ago. And people just couldn't afford it. And so what's happened is that everybody feels like they are in, remember modern times? That you're running and running and running. You figure out some incentive or some center of excellence that can actually help on quality, cost, coverage, even when you're a big plan like New York City, and then something else shifts and changes, and it's gone in a second. And so I would say that the most important thing I can say is that we do not have enough real clout to actually change the alignment of all of these things, including that which Governor Kitzhaber was talking about. Last thing I'll say is that it will surprise you, because you would think, we're talking about how do you drive down prices. Obviously, we are supporting the House of Representatives bill number 3, the prescription drug bill. You think about how to extend coverage. We are supporting healthcare as a universal right, even though we believe there are lots of different ways to get there. And we have to be careful about the unintended consequences of just a soundbite and not actually thinking through what it means. But this is the thing that will surprise you. Rural areas. And this is the one place where I actually differ from Governor Kitzhaber, which is value is vital, but if every rural hospital has closed in an area in 20, 30, 40, 50 miles where there's nothing, how do you actually do something to ensure that there's some preventative health care or some emergency health care or a gynecologist, an obstetrician in a county like McDowell County, West Virginia? How do you create or recreate a family structure and things like that if you don't have that? So this is a bigger, so we have been very focused on how do we actually fight back for rural hospitals? How do we deal with surprise billing? How do we deal with the opioid crisis? That's why you see so many strikes right now in teacher strikes about also fighting for community schools and wraparound services so that the schools can be the center that are providing mental health services and nurses and guidance counselors and things like that.
Thank you very much, Randi. So, Rushika, Randi represents quite a few providers. You yourself are a provider, a practicing doc, and you run a really unique practice that I think in a lot of ways sort of upends the value proposition from what we see in almost the entire rest of the healthcare industrial complex. Can you talk a little bit about Iora Health, what you're trying to accomplish, and how you think this could spread?
Sure. So it's great to be here. I think this is an incredibly important conversation for all of us. I think, as we said, healthcare is a huge, huge problem, and it's done incredibly poorly. So I'm a primary care doc, and I think the proposition is that we had built this sort of medical industrial complex, to use your words, of providers and health plans and pharma companies who, in general, despite the rhetoric, have zero incentive to change the system. And to be honest, it's a flip, are spending huge amounts of money to preserve the current system. Yep. And what the current system is built to do is do more stuff to us. Not make us healthy, but do more stuff to us, which, by the way, often does the exact opposite. Mm-hmm. And apart from confiscating all this wealth, $1 trillion a year of wealth that's being confiscated away from things that we should be spending it on, and not bigger hospital towers and a bit more private jets for health plan execs and the like. So we decided if we want to actually fix healthcare, we have to fix how actual care is delivered to actual people. And the way to do that is not start top down with these humongous people, but start bottom up with people. And that the next step up is really primary care. And we could use primary care as a lever to actually fix healthcare. Why is that? It's a great place. So yes, we can fix the usual primary care, get your care, manage your chronic disease, but more importantly, as Governor Kitzhaber said, a huge amount of actually health, which is the goal, by the way, not healthcare. A huge amount of health is actually nothing to do with healthcare. It has to do with relationships and poverty and relationships and how you eat and how you exercise. And we can help with that through primary care. And then no matter how well we do primary care, people are going to need the access to the rest of this big bad system. And as I said, the US healthcare system, its predilection is just to do more stuff to people, suck people down a vortex. Thinking individual consumers, by the way, give them skin in the game, high deductible plans will fix that problem is fooling ourselves, mm-hmm. Yeah. Right? These are too complex problems. The power dynamics are way too important. Mm-hmm. A consumer can't push back on a cardiologist trying to do an unnecessary test. I can as a primary care doctor, and I can work for the patient. So the idea is we need functioning primary care, and this is key, that works for the patient with a period at the end of that sentence. Not, by the way, for the health system, because then your job is to feed the beast. And over again, health systems are buying up primary care practices, and then they can tack the stupid facility fee on, and the regulators seem completely blind to the sort of antitrust violations going on. And then number two is the health plans buying up primary care practices, which is, the fox guarding the chicken coop again. Mm-hmm. So we want to figure out how do you build strong, independent primary care that works for consumers and can be this lever point. So what we do is we have to get paid differently. So we work with progressive employers, we work with progressive union trusts. We now work in Medicare Advantage. For folks in Medicare, we're about to be able to directly work with CMS through a thing called direct contracting. We build practices from the ground up in communities, largely low-income places, where we say, let's just start from scratch. And what would the delivery model look like if we wanted to actually improve health and not do more stuff to people? And so we have big teams with health coaches from the community who speak the language of the people they serve. We teach people to eat. We take them for walks. We are able to communicate through text messages and emails. We'll send a Lyft to go pick you up if you need a ride to have them get to us. Build a de facto narrow network of folks of excellence that we work with, and they stop acting well, we fire their ass and get someone who will, right? It's look out for the consumer. This is not hard. We all know the right thing to do. The problem is the vast system doesn't do it. And by the way, the impact is tremendous. So we see over and over again, when you do healthcare right, 40% drop in hospitalizations, 40. 30 or 40% drop in ER visits, similar with specialist visits and procedures. We drop healthcare costs by 20%, 20. That's a huge number. We worked with a union in Atlantic City. They were able to give everyone, for 7 years, they hadn't given a raise to any of their workers because all the compensation they had negotiated were going to healthcare costs. So really, crassly, the cardiologists were driving bigger Jaguars while the $12 an hour maids were not getting a raise for 7 years. We put 50 cents an hour back in people's paycheck because we were able to lower healthcare costs, right? That's what we have to do, but it requires being bold. And I think, unfortunately, we'll talk more about it. It requires not thinking we can make little tweaks to the system, and maybe we need to sort of start over, make people declare, are you with us or you're not with us? If you're not with us, we aren't going to work with you anymore. So that's what we're doing. We're tiny, by the way. We're 49 practices in 12 different markets in the US. But we're growing at about 50% a year, so we're growing fast. There are a few other folks like us who've just been fed up of trying to work internally within these medical industrial complex, and maybe we need to build a new system that's accountable in a different way.
Let's talk about that. I just want to say, employers and physicians want the same thing. Healthy patients are healthy employees.
Absolutely.
We are completely aligned. We want to work directly with physicians, particularly in primary care. A friend of mine says, going through a health plan is like being at the UN with a bad translator. We actually want the same things. We actually also have a QI team. We worked with primary care practices around California, funded by CMS. In 4 years, we saved $345 million by avoiding 67,000 unnecessary admissions and over 50,000 ED visits by investing in primary care and supporting our physicians. So this is a huge opportunity to partner.
So by the way, when we call what we do high-impact relationship-based care, one of the original sins we have in healthcare in the US, we've turned it into a set of transactions. Document, code, bill next. Document, code, bill next, and all these inane games of how to bill higher. There are tons of people, that's what they do. But if you say, let's build a relationship, it's not just doctor-patient, but it's with the community, it's with the payer, it's with the employer, then things all of a sudden start working out better.
And the same is true. I mean, if you think about what the union movement did years and years ago, one of the first things it did was to work with doctors, primary care doctors, to create primary care clinics.
Exactly.
And this kind of notion of building those relationships. But you're completely right that the health systems, by the time you actually get to a doctor or even a PA or whatever, after you've been on the phone for many, many hours, everything is about the data and the standards and the compliance and whatever. But the question I have for our doctor friend here is, how do we, I can see, is this okay if I ask?
Please.
Question? Sorry, I realize.
That's all right. No, it's good.
Oops. If you have 3 pretty heavy hitters here, but the power dynamics of the entire system is not something that any of us could penetrate on a system-wide basis right now. So the question I have is, I am wondering if we could actually, right after we get off stage, share cards, figure out how to actually interface on that kind of bottom-up way. And how to actually start working with other employers, to have that kind of clout, to do this kind of stuff.
Yeah, so I have given up on trying to change our healthcare system top-down because we have a dysfunctional political process and a dysfunctional money process. We will always lose that fight, I think, as you mentioned. Surprise billing is a great example of that, where there was broad bipartisan support for surprise billing, a very popular consumer issue. By the way, it's not surprise billing. This is a business model that is being used by a number of health systems to intentionally put people like radiologists and anesthesiologists and adjunct people not in networks. They can charge 10 times the Medicare rate, 10 times, and just shaft it on the consumer. This is not a surprise to anyone who knows what's going on. And guess what happened? The PE firms that support these companies put $45 million in at the last minute and pull the rug out of it. So again, I think we have a dysfunctional political process. We're going to have a different conversation on how we fix that. But I think the way we're going to fix healthcare is bottom up, not top down. It's going to be local. right? And the way we're going to do it is, the power we have as consumers is we can vote with our feet. That is the power that no one can take away. So I think what we need to do is create alternatives. That's what we're trying to do, and other people. But then the key is have the guts to vote with their feet. And if people are not going to work the way we want to, we stop sending them business. No one can actually stop that from us, right? And I think it's, and the fight's local too. And another point is, I think the victory you guys had in California was exactly the right thing. That I think we try to take on national fights. These interests are very concentrated. And at the national level, that concentration works against us. If we do this in every local area, they can't take on all those fights, right? The concentration then works against them. So I think this is gonna have to be a battle that's bottom up, that's patients voting with their, patients, consumers, all of us voting with our feet, and it's fights at local levels. And that will actually change the system, and maybe only that.
Thank you very much, Rushika. I worry when you talk about doing bottom-up reform as opposed to top-down reform, a person who's made his career in federal lobbying, you're putting me out of business, but maybe we can try to hit it from both ends of the spectrum. We're getting some great questions from the audience. Thank you all very much. I'm not sure we'll be able to get through all of them that I've gotten, but we'll do our best. So the first question that I received is a terrific one, a complex question, and I'll read it aloud and then interest to get answers from many of you. If we were able to squeeze the 50% or so level of waste out of the medical services system, what would it take politically to guarantee that the investment of this roughly $1 trillion goes into actually improving social conditions that cause poor health in the first place? It's the so-called wrong pocket question. We squeeze the money out. How do we make sure that it doesn't just go back into some other hands where it's not actually helping?
Look, it depends on who controls it.
Right.
And if the insurance companies, the healthcare systems, and the pharmaceuticals still control it, it doesn't actually matter. They'll squeeze it out and they'll make it, profits for CEOs. Mm-hmm. And I think that the issue becomes, how does the consumer, or the provider, have some more power in this, and that you align the incentives in a very different way. The healthcare system is supposed to be to help people be healthier, mm-hmm. or to save lives. But the people that have all the power in this, mm-hmm. frankly, are the insurance companies, the healthcare systems, and and big pharma. And so, squeezing it, there has to be a way that the consumer has more power. And I'm very intrigued by this kind of bottom-up. Yes, we have to figure out how Medicare, Medicaid, CMS, all of these monoliths or things on the federal government side, how it is aligned better. But like relationship-wise, for example, why is there not a premium payment for primary care physicians? Mm-hmm. Why is that not paid the best dollar, the most dollar, so that the incentives are aligned to do what you were just saying, instead of the other way around? So there is a federal role here, and there needs to be that kind of work done. But if the three big entities always actually have the last word on federal legislation or regulation, and we don't have that clout, mm-hmm. we're never going to change it, even if you squeeze out 50%.
There's no easy answer. There's no silver bullet to this. I actually believe in both bottom up and top down. Me too. I think it's going to take all of us coming from all angles. And another thing that is somewhat surprising, perhaps, is that my large employer members, again, the biggest private companies in the world, are going to Congress now, and they're saying, we need price caps, mm-hmm. for pharma. We need transparency for some of these costs, accountability. And they would not have done that if the market worked. The market is broken. So it's going to take heavy hitters going to Congress and demanding accountability. It's going to take contracts written by employers that don't allow sort of profiteering. And it's going to take partnership with primary care providers and community providers and nurses and others to actually help improve health. So I think it's all of the above, and that's why we need each other.
That's great.
Just very
Anything you
quickly,
wanna add,
I think
Rushika?
the key is we have to shift accountability not for healthcare, but to health.
Exactly.
The goal of the healthcare system is to make us healthier, period. Not do more stuff to people, not provide profits to people, but make us healthier. So if we make accountability on health, then we will start seeing the investments flow to different things. The one other piece, just a subtle piece, is we also need to have a long-term thinking on this. I think too often the way we've set up our capitalistic system with quarterly profit statements, annual insurance renewals, actually gets in the way. Because what we're trying to do here is actually fundamentally change behavior of docs, behaviors of patients. You don't snap your fingers and that happens. What we've seen is when you start doing better healthcare, we actually may make costs rise in the beginning because we're picking up on all the underuse, the important things people don't do. But over 2-3 years, that considerably goes below the line. So we just need to also have a much longer term thinking about solving these big social problems.
That's great. I have one very quick question. Our time is basically wrapping up here, and unfortunately, this is the way that it tends to go. Is we have a lot of good discussion, and then never enough time. A questioner asked a sort of messaging question, and the question is the question is clear. The intonation is ambiguous because it's written on a card instead of spoken by a person. How can we talk about reducing waste in the healthcare system without talking about profiteering of insurance companies, pharma, hospitals, and their executives? And the intonation is, I'm not sure whether the person thinks we should be talking about it or not talking about it, but it gets to a messaging question. If we can do it fairly quickly, I would love to hear your answers, and then we're going to have to make way for the next panel.
I think the secret that everyone should know is that better care costs less. Getting the right care, highest quality providers actually cost less. So you can take 30% out of the system, and it's not rationing, it's not limits on access, it's actually getting people the care they need, and then putting those resources into what makes people actually healthy. Incomes, housing, education, nutrition. So I think it's entirely doable.
We never talk about taking things away from people. That is the surest way to get things off. Lowering healthcare costs is a side effect of the actual intervention, which is actually doing the right thing.
Yeah.
So if we do the right thing, which actually means giving more to people, more health coaches, more prevention, more time with their primary care doctors, the side effect, and it's really hard for people to fight against side effects, by the way, is that these unnecessary things start going down, right? And it's hard to fight against that sort of a goal. So again, I completely agree. It's a side effect.
Randy, I'll give you the last word.
So, of course we have to squeeze profits out of the system. This healthcare should be a public good as opposed to a money-making venture. And it's become a money-making venture instead of a public good. But the second thing is, there's huge cognitive dissonance because people think if you pay more, you're going to get better, as opposed to this notion of if you actually do preventative care and actually focus on someone's health as opposed to the health care, then actually you're going to actually help people live longer and healthier.
I should make one quick comment. We'd be really careful because there are a ton of, quote, not-for-profit actors in the healthcare system. Many of them, particularly some of the Blue Cross plans,
Completely agree.
and they are the most egregious actors
Completely
in terms
agree.
of what they're doing to rape the system.
Right.
So we cannot let them hide behind. And they're paying their executives $13 million a year, and they're flying around private jets. And
Yeah.
I
we
believe
just have to be
Sutter
really
Health is a 501c3. Am I right?
Absolutely.
Absolutely.
Yeah, so we just have to be very careful not to blindly follow this rhetoric.
Completely agree.
Please join me for thanking this terrific.
Thank you.